and welcome to the Humans of Clinical Academia podcast. I'm Judith Johnson, your host. In this series, I'm exploring the lives of the people behind the research papers. Each episode features a leading clinical academic and shares their journey, finding out what attracted them to healthcare, how they entered research, and how they face the challenges that have come up along the way. These conversations reveal the dedication, passion, and unexpected paths that shape outstanding clinical academic careers. Beneath our skin lies an intricate, almost magical process that we rarely consider until something goes wrong. Wounds are not just injuries, they're complex battlegrounds where biology, medicine, and technology converge. From the orchestrated dance of inflammatory cells to the remarkable regeneration of tissues, wound healing represents one of the body's most sophisticated repair mechanisms. Yet, despite centuries of medical advances, wounds still challenge clinicians daily. Our guest today has pioneered new and novel treatments for wounds, finding out which treatments are most effective, those which are preferred by patients, and those which make financial sense. Have you ever wondered if putting maggots into a wound to clean the dead flesh might help with healing? Sounds icky, but you feel intrigued? Our guest today has conducted research to answer that question once and for all. With more than 260 published research papers, her work has shaped the way that our wounds are treated by clinicians today. Professor Dame Nicky Cullum, I can't wait to chat with you about your career today, but we always start Humans of Clinical Academia with our guest's favourite drink, or one of our guests' favourite drinks, and why they've chosen it. So tell me, what are we drinking today?
So thanks, Jude. So we are drinking kombucha, and this happens to be ginger and turmeric flavour, which I've never had before, but is absolutely delicious, so thank you. And we're drinking it. Well, I do like the taste of it. I don't really like sweet things so much, and I am of a certain age. I'm at the age now where one gets obsessed with gut health. And so I believe that drinking kombucha and eating fermented products like kimchi and sauerkraut is really, really good for your gut microbiome. So that's why we're drinking it.
So do you ever drink like coffee?
Yeah. I have at least one, if not 2 cups of coffee in the morning. I drink loads of black tea.
So this is just part of the picture.
Part of the picture. And also love beer, cask ale, but I thought it was too early in the day really for that.
I have heard that beer can be quite good for gut health too. Is that true?
I don't know. But I don't care. I just like drinking it.
I hope so. But I don't want to be giving out any dodgy health advice on this particular podcast. That's for my other podcast. Okay, so Professor Dame Nicky Cullum, you have researched a wide range of things, but your main area of interest has been wound healing. Can you tell us more about what your research in this area has shown?
Yeah, it's funny. Yes, I'll try my best. But if you look back over your research career, so I'm near the end of mine now, and you try and boil it down to what amazing things have I discovered or found out. And actually, it's always disappointing. It's relatively few, I think, because even a massive piece of funded research usually generates a tiny increment of knowledge. But I'll try and summarise a few of the highlights. So we did do some basic epidemiological surveys to find out, well, okay, how many people have wounds? Because actually that data is not readily accessible via our health data systems. So we had to do surveys to find out how many people have wounds, what kind of wounds have they got, how are they being treated, that kind of thing. What kinds of people have what kinds of wounds? And so we did find out some, I think, really useful stuff about that. So we found the size of the chronic wounds problem in the UK, and we found that approximately 0.03% of the population have a venous leg ulcer at any time, which is about 21,000 people. But those 21,000 people need a lot of care. They need a lot of nursing care. They need a lot of treatment. It's a very unhappy thing to have because it impacts on your quality of life a lot. So we've looked at that. We found out how much these wounds cost. So we estimated each year just venous leg ulcers cost about 80 to 100 million pounds, depending on various factors. Then we looked at the treatments, and we looked at the evidence for the treatments of the commonest chronic wounds that affect the the biggest numbers of people. And we did a trial. So what we tended to do, what I've tended to do throughout my career, is do systematic reviews of the evidence for particular ways of doing things or treatments or whatever, ways of delivering care. What's the evidence? Summarise that evidence scientifically, enables you to really know what we know and pinpoint the gaps. What don't we know? And then sort of the research agenda follows naturally then in the high priority areas that affect a lot of people or make a lot of people very unhappy. What are the key research questions? So then we moved to look at, what's the evidence for compression bandaging? Because that is the compression treatment. That's wrapping treatments, bandages or stockings tightly around the leg is the best way of healing these venous leg ulcers, because basically your veins have failed and the blood is pooling in your legs and not getting pushed back to your heart, and the skin breaks down. So we looked at different ways of healing those, and we trialled in proper randomised controlled trials different commonly used bandages to find out, let's not just go on custom and precedent, let's actually find out which ones work and which ones are cost effective and which bandages or stocking systems mean fewer visits from the nurses, because that's a really expensive way of delivering care. So we found that a 4-layer compression bandage was superior to another one that was sort of being introduced in the UK in the 1990s, where we found that this new European short stretch bandage, which was new to the UK, was not as good as the thing we were already using. So that was good to know. It supported current practice. And then we also looked at whether putting 2 layers of a tight below-knee stocking, compression stocking on, for people with an open venous ulcer, which would have a dressing covering it, could be a better way of doing it than wrapping loads of unsightly bandages around people's legs. And we found that it was pretty much the same in terms of healing. It reduced recurrence and it was less costly, because you wash and reuse the stockings, less skill is involved. People can often look after themselves and look after their own leg ulcers, so that opened up other avenues of treatment, reduced costs, so that was good to find out. We did look at fly larvae, as you mentioned at the beginning. We looked to see whether specially bred sterile medicinal larvae, which by nature clean up debride wounds. They get rid of the sloughy dead tissue and make the wound look cosmetically clean, but does that speed healing? And they were being heavily promoted and marketed at the time, and they're quite expensive because you need to breathe them in sterile conditions. Do they make a difference? So we did a trial of that and found they made absolutely no difference to healing venous leg ulcers, even though they did make them look clean. And patients didn't like them actually because they were quite painful. They don't bite. I mean, they digest the material by secreting enzymes and then sucking them up. But I think people found it quite uncomfortable. I mean, they may work for other types of wounds. I haven't looked at the evidence for other wounds recently. There wasn't any before, but they certainly don't make a difference to venous leg ulcers. So that was good to know, I guess, because sometimes the negative findings are quite useful, because at least you know, okay, we don't need to spend loads of money on that thing then because it doesn't work. So there's some of the highlights.
Well, it's time for your first picture. This shows you on a swing wearing a nurse's uniform, and you look young, aged about 4, I believe. Can you tell us about this?
Well, I remember getting the nurse's outfit. So this would have been about 1965, 5 or 1966, something like that. I think it might have been just before my little sister was born, and maybe I thought I was going to help, when she was born, by having a nurse's outfit. I think that might have been it. So I was on a swing in the back garden for the house that I first lived in when I was little. And I remember the excitement of getting that nurse's outfit, because it had a little plastic case in it with like pretend syringes and tweezers and all those I thought, oh gosh, being a nurse must be really, really exciting. So that's a kind of vivid memory for me. And just, I guess I saw at age, 4, saw nursing was about being helpful, I suppose, and I thought I was going to help. Of course, I wouldn't have helped at all with my mother and the small baby. But so I just think that's the first evidence that I thought of being a nurse, maybe.
Professor Dame Nicky Cullum, you trained and registered as a nurse, but both your undergraduate degree and your PhD are in pharmacology. Can you tell us more about this? How did you come to do this kind of dual training both in pharmacology and nursing at the same time?
Well, firstly, I didn't want to be actually, although the nurse's uniform thing, age 4, gave a sense that, maybe I always wanted to be a nurse. Actually, I then decided I wanted to be a vet. I was obsessed with animals. And so spent all my schooling then, I just went to a comprehensive school, but I was obsessed with being a vet, so I did science A-levels. What I didn't really understand was how to revise, or even that you had to revise for exams. Nobody in my family had been to university. Nobody could give me any guidance as to how do you prepare for exams, or I probably didn't even ask for it. I mean, nobody really talked about that sort of thing in those days. So I didn't get the grades, despite having prepared myself scientifically with 3 sciences to go to vet school. So you were encouraged to put a different, because veterinary school was so hard to get into, to put a 5th choice down that was something that was a bit easier. So I found, I don't know how, but I found, when I went for a careers talk anyway, the careers teacher at school said, you'll never get into veterinary school, be a nurse. That was right. So I got given loads of stuff about nursing. But I did read it, and actually I think fundamentally one of the reasons why I wanted to be a vet was because I like people. And actually you're dealing with owners as much as you're dealing with pets. I'm so glad I wasn't a vet, by the way, now. But it was a massive disappointment at the time. But anyway, so I read this and I found this one degree course, because nursing was not a graduate profession at all then, but there were degree courses, and there was this one that I liked the sound of, that was at Liverpool, that was a life sciences degree. Any life sciences degree of your choice could have been marine biology, anything. And what was then, I think, an SRN, a state registered nurse qualification, sandwiched around each other over 4.5 years or so. So you got 2 qualifications for the price of 1. You learned to be a nurse on the wards. It was very much the apprentice model of nursing. You were part of the rostered workforce. You weren't supernumerary, so you were working as a student, delivering care, like all students were then. So that's what I did. So I chose pharmacology because I'd always been interested in medicines and how they work. I don't think I really knew what pharmacology was, to be honest. I mean, this is one, again, most of my career decisions have been sort of haphazard. And this was another example of a haphazard choice of a degree, because I thought, that'll go with nursing. But actually, I hadn't really worked out that nurses were not then anyway prescribing any medicines. They were giving them out usually, and I guess it was useful to know how they worked. But I wasn't making any decisions based on the science that I'd learned. Anyway, so I enjoyed it. I did enjoy it. I did the degree, and then ended up doing a PhD as well, just because there was an opportunity that I grabbed to do a PhD in the same department in a topic that related to my undergraduate dissertation. They got funding and they said, do you want to come back? So I grabbed that opportunity.
With your undergraduate, that sounds like a fascinating way to become a nurse and also study a life science. Is that kind of dual training open to nurses today?
So it went very much out of fashion, and in fact they closed down the course that I did, I think a few years after I left, but not a very long time after I left. And that was a real shame, because I think it was a fantastic training. And it's coming back in now, I would say, partly because the shortage we've got of nurses. So there are lots of people who've done other degrees, and then nursing becomes quite an attractive proposition when, for whatever reason, when you're a bit older and maybe you can see the value of it in a way that you couldn't when you were 16 or 17. So I think at Manchester, our postgraduate pre-qualifying masters, where people come in with a degree in something else and then do a much shorter course to become a nurse, is the closest thing probably to that. And I think there's massive advantages to it. I would never say it's better, but I just think for some people that's a great thing to do.
How do you think nursing becoming a degree model as standard has changed the profession?
Well, we know, research has shown us that if you've got more graduates working clinically, care is safer. People are less likely to die. People are less likely to be readmitted to hospital. People have shorter lengths of stay. I think nursing now, compared with what it was in the, say, 60s and 70s, and even 80s, is much more complex. The decision making is very complex. And so by preparing people at degree level, you're preparing them to participate in these really complex decisions about patient care. I also think it means that we're working as an equivalently qualified member of a multidisciplinary team, and I think that's really important. Plus, it enables us to do research that propels the profession forwards, I think, because you can't do that really if you haven't got a degree. So I think there's hundreds of ways in which I think everything's better since we started doing degrees in nursing. And I think we were later than most of the other allied health professions in terms of when we started to become a graduate profession. So and that's partly why I think our research is in some ways less developed. It's been slower to get off the starting blocks because we were only relatively recently a graduate profession.
It's time for your next image. This shows a wound dressing. Can you explain this to us?
Oh, and in fact, so I put in a picture of a 4-layer bandage for this because this is the bandage that we evaluated in the trial I mentioned before. But because I was going to put some pictures of wound dressings in, but they're all either commercial or they're copyright protected. So I put one of our own photographs in. I think it was just as a marker to say the first undergraduate research project that I designed. It was an assignment that we had to do. We had to design a piece of research, and honestly, I had no clue about research, either from really about human research, actually, health research, either from my pharmacology degree or even from my nurse training, because we didn't really do much on research. But we had to design something, so I wanted to design an evaluation of a wound dressing as my, because I was working in vascular surgery and I really liked wounds, wound care and changing dressings, but I really didn't know one dressing from another and didn't have a clue as to how you would decide what dressing is better than another dressing for a particular sort of wound. So I designed that was my first foray into wounds research, very much a paper exercise. I do know, as I say, I think it's important to say for nursing students particularly that, I found research very confusing as a nursing student. I don't think we were taught very well. I think we were taught by people who didn't understand it themselves. So, what chance did we have? And I think that's better now. And I think we've probably still got a way to go. But the more you do research, I think the more addictive it is. And I feel like I've sort of worked out how to do it now.
Professor Dame Nicky Cullum, you quickly moved into research after qualifying as a registered nurse. And you've mentioned just now briefly how that happened. You moved from pharmacology undergraduate, took an opportunity to do a PhD also in pharmacology. Can you tell us a little bit more about how that happened?
Yeah, so I was, I'd been qualified a few months, and I was a staff nurse on a vascular surgery ward in Liverpool. And this would have been about 1985. And things are bad now in the NHS, but my memories of it then were horrific. There were strikes, there were picket lines, so due to, I think it was about pay largely, but there were massive concerns about staffing levels. And, I would typically be in charge on a vascular surgery ward, having only just qualified. And with student nurses and pupil nurses, as they were then as well, who had only just started their clinical experience, and I felt very exposed, I think, and it didn't feel safe, and I was really, really stressed. And so out of the blue, I got a phone call from the department I'd done my degree in, and they'd just got funding for a PhD. Did I want to come back? It was similar to the thing I'd done for my undergraduate dissertation. Did I want to do it? Now, this was a diabetes project, and my dad, I was brought up mainly by my dad as a single parent, and he had type 1 diabetes from when he was 17. So he was one of the early recipients of insulin treatment, actually, relatively early. So he was diagnosed in the, I think it would have been the late 40s, early 50s. So I knew a lot about diabetes from the point of view of being the child of somebody who had quite unstable diabetes, and was starting to have health problems from having had diabetes for a long time. So I jumped at the chance to go back, do something completely different. I didn't know what a PhD was, if I'm brutally honest. I had no idea really, but it was just an opportunity to do something different and maybe sleep better at nights than I was doing as a staff nurse, really stressed. So that's what I did. So I went back, and it was early in my nursing career. I'd never planned to do it. Having said that, if it had been an opportunity to come later, I don't think I would have been able to do it, because I probably wouldn't have been able to afford it. You know, you did PhDs on grants then, but I was used to being poor because I'd been a student for so long. So, you know, it was just more of the same, really. And if I'd gone on further in my nursing career, it would have probably been much more of a career risk that I wouldn't have done it. So well, for me, it worked really well doing it really early, I think.
Mm. Your early research involved rats, and you also published papers in diabetes, so that kind of is coming through in your early publication records. How did you then make the shift to researching wound care instead?
Well, two things really. So part of my PhD was involved going to diabetes clinics in the hospital, because one of my supervisors was a consultant diabetologist. So I sat in loads of clinics, and I was recruiting, well, I wasn't recruiting patients to a study so much as asking if I could have some of their blood. I was using some of their blood in my research. So I was sitting in clinic appointments and learning so much about diabetes, care and the complications of diabetes and so on. So that was that aspect of it. And then obviously when I'd got my PhD, or towards the end of my PhD, I realised lab research wasn't really my thing. So not only did I make rats diabetic and maintain them with insulin therapy and then get lots of samples from them, but I also went to abattoirs every week to get brains from pigs to do part of my research on. Anyway, lab research is right for some people. I just felt it was far too far away from the people for me, from the patients, and that I really wanted to be much more applied. So that and the clinic experience, and also the realisation that it's all very well doing a PhD in pharmacology, but actually as a nurse you can't really use that knowledge, that lab knowledge, in clinical decision making so easily. Whereas if you do much more applied research with people, then it lends itself much better to the nursing aspect. So I looked around for research opportunities in nursing, and found some for a 2-year postdoc in Surrey in a nursing practice research unit that was funded by the Department of Health, as it was then. So what is the Department of Health and Social Care now? So I went there for 2 years and working on a wounds research program.
Oh, fantastic. That sounds like a perfect fit.
So it was great. I hated Surrey, but because I'm from Yorkshire, so, it's a very different environment. But worked there for 2 years. Yeah, it was yeah, good. It was a good springboard to other things, actually, a really good springboard. And that's where I met Dawn Dowding, actually, subject of one of the earlier podcasts.
Yeah, brilliant. I think that's episode 2, so shout out for that. Okay, so it's time for your next image, which shows a Cochrane logo. Can you tell us about this?
Yeah, so people may or may not know, but there is a movement really called the Cochrane. Well, it was called the Cochrane Collaboration. It's now called Cochrane, and it was born in 1993 in Oxford, and it was based on the idea that healthcare decisions should be based on accurate summaries of the research evidence about that decision, relating to that decision. So systematic reviews, these accurate summaries are called, that should be kept up to date as new research becomes available. So when I was at the University of Surrey, I started doing a systematic review of leg ulcer treatment for the Department of Health. But I didn't know what a systematic review was. But the director of that unit, an amazing woman called Rosemary Crowe, who was one of the first professors of nursing in this country and also a psychologist, who was Dawn's supervisor, she had met a man called Ian Chalmers, and she introduced me to him. And Ian Chalmers was then the director of the National Perinatal Epidemiology Unit at Oxford, and he had started doing systematic reviews of interventions in obstetrics and maternity care. And it was a really famous book. It was like the Bible for what was the evidence base for obstetric interventions and perinatal care. And he was now at this point going to be funded by the Department of Health. In fact, it was the National Health Service Research and Development Programme then. It became NIHR. But he was funded to start looking at how we would set this up for the whole of healthcare. So not just for obstetrics, perinatal care, but how do we summarise the evidence across healthcare? So he was trying to set up an international movement to do this, of volunteers essentially. And because I met him via Rosemary Crowe, he wanted me to be part of it for nursing. So I was really excited to do that, and ultimately, nursing sort of, I sort of argued that actually we shouldn't be doing it for nursing as such. There should be a nursing element to any of the themed topics, and the topics tended to be diagnostic groups, or like mental health, or stroke, or in my case, wounds. So I set up a wounds review group, which was one of the first ones. I think it was set up in 1995, and we did systematic reviews. Or I say we helped people around the world do these systematic reviews that had to be done to an international standard, and then they were published and available via this thing called the Cochrane Library. And that Cochrane logo is a great, I think, a great logo, because what it does is it summarises the evidence as it was at the time of the beginning of the Cochrane collaboration for whether giving steroids to women who were at risk of delivering premature babies, whether it was likely to reduce the baby's risk of breathing difficulties after birth. They summarise the evidence, and that meta-analysis is what the logo is, shows that the steroids did, in fact, reduce the risk of breathing difficulties. And so that became the logo for the collaboration. But it is a meta-analysis, which is essentially what we were all trying to do in these systematic reviews, to find the answer from all the previous research. But it was a great thing to be part of, and we led the Cochrane Wounds group until relatively recently, a couple of years ago, when the funding stopped in the UK for doing it. So I can't do it anymore. But a fantastic way to learn about research, about how to do research really well, about how to write about research really clearly, and about how to collaborate with people around the world in doing all those things. So Cochrane was just a fantastic, serendipitous opportunity for me, from which I gained so much.
So, Professor Dame Nicky Cullum, let's go back to the start. You were born in Leeds in the 1960s and growing up in the 60s and 70s. What was that like?
Well, I suppose I don't really know because I've got nothing to compare it with. But it was quite hard in a way. So my mum wasn't well, and my parents separated when I was relatively young, sort of probably 12, 13. My dad brought us my sister and I up. Money wasn't that plentiful, but. So my dad, who was an engineer, who did mainly the kind of engineering, well, he was sort of middle management probably, but he also got his hands very dirty doing it, and used to fix cars as well in his spare time. So he seemed to work all the time. So what I got from him was this crazy work ethic, where he would work six days a week and then work on other people's cars in his spare time in our cellar. And he hardly took holidays. It seems crazy now, but that's what he did. And I love Yorkshire, which is why I'll talk a little bit about Manchester. But it's hard to move here from Yorkshire, I guess. But I mean, a great time to live, to grow up, because the music of the 60s and 70s was so fantastic, and Leeds was a great place for music. And then I think that's partly why I went to Liverpool as well, apart from the courses, because Liverpool was then a great place to go in 1980 for music. So yeah, it was good times.
You mentioned Manchester, and this moves us on well to your next image, which shows us an image of Manchester. Can you tell us more about this?
Yeah, so I took that photo in lockdown firstly, I moved to Manchester for work in 2011, and moving to Manchester was never part of my plan. I was at the University of York for 17 years. And was really, really happy there until suddenly I was very unhappy for, work-related reasons. And I just at 2011 thought, I have to get out of here. And had a really good colleague, Karen Luca, who was head of nursing here, who I phoned up and said, I don't suppose you've got any jobs, have you? I really need to move, but I need to move somewhere commutable from Leeds at the time because my kids were still at school. Anyway, there was funding for new professorships across the University of Manchester, and so I was very lucky to be interviewed and to get one. So that was a shock to my system, but I commuted until not long before lockdown, and then I moved, and my kids had gone away to university, and I moved to Manchester, living in a flat in Ancoats, and then lockdown happened. So that was a really scary time, as it was for everybody, I think. But one of the things that kept me sane was walking miles. I was living with a wonderful flatmate as well, I have to say, a colleague from the university, a great flatmate. But walking miles was what kept me sane. And so that photo, which was on leg one of the Greater Manchester Ringway, which I wholeheartedly recommend to anyone. It's basically a walking route around the whole of Greater Manchester. It's down by the canal in the centre of Manchester, that photo. But so I physically moved to Manchester. I didn't think I would like it. I didn't expect to love it. I absolutely love Manchester now. Not only personally, but actually professionally, this is the best time of my career, really. It's the best time I've ever had. So, fabulous. So that was, I was trying to find an image of Manchester that I'd taken that symbolised, what I really like about it. And that kind of industrial landscape and the railway bridges and the canals, I absolutely love it.
You've said that you can't plan a career too tightly, and that crushing disappointments can lead to the best unanticipated opportunities. What have been some of the best turnaround moments in your career?
Well, there've been and I've alluded to some of them. Not getting to be a vet, it was crushing. I was devastated. Thank God I didn't get to be a vet. I would have been rubbish, I think, and I would not have, I think, had the joy that I've had in my career. So, and then realising, having done a PhD in lab research, I didn't really want to do lab research was a bit of a moment. And having then to sort of teach myself how to be an applied health researcher, because we hadn't really done that kind of training in my PhD. But that's fine. It was fine. you can do that. You can turn it around. You can do research in different things from the ones you've trained in. And sometimes that gives you a perspective that is absolutely helpful to a new way of thinking, and fundamentally, I think, to interdisciplinary research. So that was good. I failed to be awarded a nursing research postdoctoral fellowship by the Department of Health in 1994. And it was awful. I felt I'd almost been promised this thing, and I was interviewed for it. I thought the interview was okay, but I didn't get it. Somebody else got it. And it was at a moment when I was actually I'd come to the end of my employment contract as well. It was a fixed-term contract. I'd moved to the University of York on a fixed-term contract, sort of on the promise that I was going to get this thing, and then I didn't get it. And that was awful. But what I had got was this funding to do this systematic review from the Department of Health that I mentioned before. And actually, that led me to having the career that I've had. So it worked out. It did work out. I'm not sure there's anything learnable from that, well, if I do, but it did work out. So I think, it's something about the route that you think makes sense in your head isn't necessarily the route that's the best, and that often the most disappointing and unexpected things can actually turn out to be much better than the route you would have taken if it had gone to plan. So the other thing would be having to leave the University of York when I felt my position had become untenable, but I thought I'd see my career out there. I've hardly moved in my career. I don't really like moving and moving jobs, because there's a massive sort of, you almost have to start again very often, it can feel, in academia. But I'm so glad I came here in 2011. And I'll end up having worked here, if, don't want to over anticipate things, but if I work to my retirement over the next 4 years, I'll have worked here longer than I worked at the University of York, and it's been fantastic. So yeah, I don't know what the lessons are, but except you can't plan it too tightly, and things have tended to work out for the best for me anyway.
What advice would you have for an aspiring clinical academic who feels that they're just having a string of disappointments and they are still waiting for that unanticipated opportunity?
Yeah, I think, everyone says disappointments are part and parcel of being an academic, and they are, but I don't think it's enough to say that. I think we need much better strategies for supporting people and helping them through it. And I mean, the first thing I would say is nobody should be working alone. Research isn't, generally speaking, certainly not in health anyway, isn't a solitary activity. I understand that it often is in the humanities and the arts, but it's not in health. It's a team sport. So people need mentors, they need mentors and supervisors probably. They need to be part of a team. And if you feel alone and you're not part of a team, you've got to create your own team, I think. So you've got to go and find the people you want to collaborate with and build that team around you, and ask for help in doing that. There should be people in every academic department and clinical academic department who can help you do that, I think.
What advice would you have for a clinician who is getting started in research? Maybe they've done an internship and they're kind of moving forwards in the early stages of a clinical academic career, but they're looking around and not really anyone around them is doing research. How can they take those first steps towards building a team around them?
And again, I think they're going to have to reach out to the university, somebody in a university who can work with them, because who's working in an area close to theirs or is likely to be a good collaborator. I think you've got to find more senior collaborators initially who can help develop you, will increase your chances of getting grants, and will give you support and guidance. But I think you've got to pick those people carefully. They've got to be people you trust, and they've got to be people who work in an area that's similar to yours or adjacent to yours, or who've got something, maybe a method. They may be great in a method that you want to learn, not necessarily your topic. So it does take a bit of Googling probably to find people and conversations with people. But I totally get that it is hard. And I think it would be a lot harder if you're in a clinical setting with no obvious people around you to collaborate with. But I think it makes sense to reach out to academic colleagues in universities.
You use that word trust, which I think is really interesting, because often if people are effectively like cold calling, maybe trying to meet some academic collaborators who can support them, they won't know anyone else maybe who knows that individual, so they'll be going off their own experience. Are there any key indicators of trustworthiness that a clinician could look out for in a prospective collaborator?
That is a great question, and I don't have an easy answer to it. I think you should be looking for people who have published with clinical collaborators like you before and given proper recognition to those clinical collaborators in papers, in grants, can talk to you about how they've worked with people like you before. And also I think you would start building a relationship before you a potential collaborative relationship where you felt comfortable before you really get into the weeds of writing grants and papers together. Probably it takes a bit of time, but if those relationships can be brokered via somebody else who you trust, that also is very, very helpful. So I think it's like any other relationship, I guess. In some ways research collaborations are no different. You've got to see what other people think of this person, look for other evidence of good behaviour, I guess, and take it from there. But and also I would say to somebody in a clinical role, if you can reach out to your NIHR, with the National Institute for Health and Care Research infrastructure near you. There will be some, whether it's an applied research collaboration, there's 15 of those in England, or a BRC, Biomedical Research Centre, or whatever it is. Talk to them. They will have research capacity and capability infrastructure for people like you, and they may well be able to broker some of those relationships.
That's great advice. Your last image shows you with your children at Buckingham Palace collecting your DBE, which I believe is Dame of the British Empire. Can you explain this to us or tell us a bit more about this?
Well, I mean, this I felt a bit funny putting this in, right? Because I feel a bit ambivalent about the honours system, and so it was very hypocritical then to accept it, wasn't I? No, because I was awarded this in 2013, and it was a massive thing. I went to comprehensive school. Nobody in my family went to university. I got it for research, and actually I didn't feel it was just for me, obviously, because research is a team sport, and so it's for nursing research, and it's for people who've worked on wounds research with me over decades. So it was partly for that that I felt it was. But the biggest thing was feeling seen, actually. It was like, oh, okay, so you beaver away all over the place in different institutions or different things for years, and I felt seen. But the reason why I put the photograph of me and my kids in is because I probably wasn't the most present mum in the world. I worked full time all their lives. I travelled away quite a bit, and I felt it was an acknowledgement that I had actually been working quite hard. I wasn't just, it wasn't mum just trying to stay away from home as much as possible or going away. I'd actually been working very hard, and it had been seen. It was successful to some extent. So I thought that award in a way was acknowledgement of that in a way that would never have been visible to my kids, but we got to go to the palace for that, so I sort of assuaged my guilt a bit. Also, my father-in-law at the time, who's Indian and very pro work, but pro work that earns you money, could never understand why I worked so hard but clearly wasn't earning that much. So when he saw that as well, he was like, oh, right, he got it now as well. So that was great. But it was also such a fun day, and we got to meet Andy Murray, who was receiving his OBE at that award ceremony. He got knighted subsequently, but he was so lovely, and my son and I went and shook his hand, and he was so sweet, and he's a bit of a hero. So that way it was a good day out. Yes. And I wore shoes with heels on, which I never normally do, and what a big mistake that was, because I couldn't walk in them anyway.
They look like nice shoes, like nude colour. I noticed them.
Yeah, that was the only time I've ever worn them.
A core part of all clinical academic careers involves writing, whether that's writing research funding applications or writing research papers and articles. I know that for many aspiring clinical academics, it is this that most scares them about the prospect of a research career. How do you find writing, and has it always come naturally to you?
So I have always enjoyed writing, but enjoying writing and enjoying writing scientific papers and grant applications, not necessarily the same thing. It definitely didn't always come naturally to me. In the beginning, I found structuring writing, particularly, for example, results and conclusions of things, because you can write the background and you can write the methods, but then the results take care of themselves if it's that kind of paper. But also book chapters can be very different in format. So I found structuring very difficult. I think a lot of people find that very difficult. I think students find it difficult to structure things. I think I'm good at it now, but it definitely wasn't always the case. One of the ways I learned to write better actually was via Cochrane, involvement in Cochrane, and just really working out what was the message I was trying to convey, what were the essential pieces of knowledge people had to receive in order to then understand what my main message was. But I'm copying other people's writing, actually, emulating other people's writing. So Ian Chalmers, who's written thousands of papers and books and book chapters, I used to study his way of writing quite carefully, because he was one of those people who spoke in very plain English and broke things down to simple concepts, and I tried to emulate that. So it is tricky. Plan your writing. Make a plan.
That's really interesting. That's some great advice. Well, I think that brings us to the end of our interview today. Professor Nicky Cullum, thank you so much for joining us. To our listeners, thank you so much for choosing to spend some of your time with us to watch or listen to Humans of Clinical Academia. If you are listening to this interview on Apple Podcasts or Spotify and you want to see the images that we discuss, please visit our Instagram page, which is @Manchester_Catalys, or go to YouTube, where we're @Manchester Catalys, all one word, no gaps, and you'll see them there. Humans of Clinical Academia is a Manchester Catalys podcast. Manchester Catalys is a partnership between the University of Manchester and Manchester University NHS Foundation Trust to support and promote clinical academic careers, and we are grateful for their support, which has made this recording possible. I'd also like to thank all my Manchester Catalys colleagues, especially Umang Sinha, for production and editing.